For the past 50 years, we've seen leaps and bounds in medical advancements in imaging technology, in surgery, in diagnosis. But there's one diagnostic tool that really hasn't changed all that much for decades. Now, I'm sure many of you have experienced this when you go to a doctor's office and the doctor or the nurse asks you, well, on a scale of 1 to 10, how much pain are you in? Well, how accurate is that, really? I mean, maybe my 3 is your 5, and maybe someone else's 6 is someone else's 10 on their own individualized pain scale. Well, that's kind of hard to quantify. You can't really put that into a textbook. We also know that we have a large problem in America with patients that are going to a doctor's office looking to get prescription medicine. Now, what is the doctor supposed to do in that kind of scenario? When we're presented the patient who is in pain with this little graph here, and we have frowny faces and smiley faces, I mean, how does that really quantify a headache versus a broken bone? And what is the doctor supposed to do about that? Consider also a patient that's unresponsive, that isn't able to tell you how many smiley faces or frowny faces they're feeling today, or who can't really talk about their pain at all. What if you have a patient that's comatose? We've found a way to empirically measure pain from physiological responses. Even if a patient is comatose or non-responsive, we are now able to take those physiological responses and predict how much pain they're feeling. Even if a patient comes in looking to get prescription drugs that it really don't need, now we'll be able to check how much pain their body is really in. So we set up a system, an experiment, to test how a person's body responds to pain. And then we were able to use all of that data to make predictions through an algorithm of how much pain that person is really in. So here's how we did that.
As my previous colleague recognized, we have this problem of recognizing these pain levels in different participants is limited to frowny faces and smiley faces and 1s and 6s and 9s and 10s. And so with that, we set up this experiment in which we had 6 different participants, and we tested them each over 100 times over a 7-day period. 4 of these participants were males and 2 of them were females. And amongst the participants, they ranged the ages of 22 to 25. All of them being healthy and strong, having no medical illness history, no neurological history, or no psychological history as well, no disorders there, as well as no chronic pain. And with that, we measured them using 4 different machines. The first of which was an electrical stimulation electrodes, which stimulated the pain, and we attached it to their right ankle. The second machine of which we used was a BVP, which measured the heart rate as well as the blood volume. We put this on the palm side of their index finger. And then the third machine was an SLC flex machine, which measured the skin to conductance of on their pinky finger. And the fourth machine was our EKG machine, which measured the electrical signals. And we put this on the chest. And we placed it on the chest, and that way it didn't pick up any signals or any background noises that came from our electrical simulation electrodes machine. And through the EKG machine, it was a universal way of measuring the pain of which we stimulated our participants through over these tests over several days. And so with that, these tests consisted of contractions of up to 30 seconds. And so we would do that. And the first level, which we contracted and sent these electrical signals, were measuring of 20 amps. And so we'd contract these 20 amp measurements 30 seconds, and then we relaxed, and we didn't do any contractions, no stimulations for 1.5 minutes to up to 2 minutes. And then we went up to level 2, which is 30 amps. And we did that for 30 seconds. And then we did 1.5 minutes again, up to 2 minutes. And then we hit them with level 3 of 40 amps. And so we did that for our test and did each one of them for 100 times over a 7-day period.
So as my colleague just said, we measured pain in 3 different tests. The first one being our blood pressure volumes, the BPV. This measured the blood pressure of this patient, and we had a baseline to show the control. And then there are 3 stimuluses that were spoken about before. The stimulus is being at 20 milliamps, 30 milliamps, and then 40 milliamps. For the 20 milliamps for our blood pressure, we shouldn't see a whole lot of difference. In the 20, we do see that the person depicted in this result was they were starting to feel a little bit of pain, but by 30 and 40 milliamps, they were starting to feel more pain, and then eventually they hit that threshold. And that's why stimulus 40 and 20 look really similar, is because they hit that threshold to where they can no longer have an excessive amounts of felt pain. But we were able to measure that through that blood pressure reflectance. Our second test in the electrocardiogram was measuring our heart rate. So again, we have our baseline, and all these tests we're going to have a baseline so you can see the control. So at 20 milliamps, our heart, you can see because of the sympathetic nerve response, you should start to see when inflicted pain in the way that we're doing it with the stimulation, you should start to see your heart starting to race when they're inflicting pain as the body's natural response. So at 20 milliamps, we didn't see a whole lot of increased heart rate. There was definitely a response from the body, and they were starting to see, yes, we're experiencing pain through that stimulus. And by 30 milliamps, the people were experiencing a lot more pain. Their body was going into the fight or flight mode. They were feeling their hearts racing. But by 40, they hit threshold, and you could see that their body could only process so much, and their heart rate was increased and elevated compared to 20 milliamps and then our baseline. So that was an important thing to see there. Our last test is the skin conductance level. As our patients are stimulated, you'll see that their skin conductance, you should see a lot of sweat starting to appear on their at the area of stimulation. Here we'll see the baseline as our set stimulation, what it should look like, and then what happens after. So looking from the top to the bottom, as the graph goes down, you're going to see more conductance in the skin, meaning more sweat, more agitation. So at 20 milliamps, we see that the body is responding slightly to the stimulus. The body is recognizing that stimulation is occurring, that they're being shocked, that they're in pain, but it's not a huge worry. By 30 milliamps and 40 milliamps, you can see that the patients are experiencing, their body is responding naturally to that stimulation, that shock. They're feeling pain, they're not comfortable, they're not happy, and the skin conductance level is going up. It's becoming more conductive because of the uncomfortable, the shock and the pain that's occurring at that stimulation site. So 20 milliamps had really no effect, but by 40, that threshold, it was super conductive.
All right. So after we took all that data from all of those patients about how their bodies physiologically responded to those different stimuli, then we were able to take all of that data and we were able to pre-process it before, because our skin conductance level would have a different impact as our electrocardiogram. So as those varied, we were able to put that into an algorithm, and we were able to figure out what physiological signs and responses to expect with different levels of pain, whether it be around that 20 milliamp or that 40 milliamp level. So after we were able to take all of this data, then our algorithms were able to predict just how much pain someone would be in if they were experiencing these different symptoms, these different physiological responses. And that is our goal. That's exactly what we want to know. How much pain is someone in based on these physiological signs? So we're going to be able to take all that data in, learn from it, and then extrapolate from that data exactly what a patient is feeling based on these different signs if they're not able to communicate with us.
It's really important to recognize what my colleague just said. We have ways that we can extrapolate data that actually is recognizable data. This is quantified data from people experiencing pain, experiencing the stimulation that we gave them through the stim process. And through our experiment, we're able to use the different physiological responses that are actually indicative of what pain can actually do to the body. The blood volume pressure, the electrocardiogram, and the skin conductance level were all put together. They were processed. Not only did we get a subjective response on what the patients were feeling, but we were also able to get those numbers from these three recording apparatus that we used. Through algorithms, through a bunch of math, and through different ways, we were actually able to look at this data, quantify it, and place it into a graph. On the left, we have the raw data, basically the numbers coming from subjective response by our subjects, as well as the quantified data from our different machines that actually read the physiological responses of our patients. And then it moves on to this right side, the data after processing. We're actually able to see between this baseline and the 3 levels of stimulation, what numbers can be quantified. Through the algorithms, through the math, we were able to show that these numbers were statistically significant. They did show that our patients not only had a subjective response, but they also were able to, through their physiological responses, through their bodies, naturally provide us numbers that showed that they were experiencing pain. Through the algorithms or through the math, we were able to basically look at it, quantify it, and show that not only were our patients experiencing pain, but there was a number attached to that pain.
Here is a linear representation of the previous 3D graph. In the first column is our baseline. We use this to calculate accuracy for the other stimulations. We see that stimulation 20, we were able to calculate accuracy 100%. We were also able to calculate upwards of an 80% accuracy for both the stimulation 30 and stimulation 40 subjects. And this is significant. This is significant because we are able to prove, that the proposed systems in the context of pain prediction, that we are able to mitigate interpersonal variance while preserving precise scalability. Meaning that all these numbers and algorithms and equations that we have been showing aren't just algorithms and numbers and equations. These are results that show that we are able and that it is possible to take a subjective process and make it objective. And we are hoping that with these proposed systems, we can give doctors and health professionals confidence that they are able to avoid uncomfortable ethical situations. And we want to give patients the confidence that they will be treated effectively and not put through unnecessary treatments.
The way that we want to express how important this is really conveyed in what my colleague just said. This is the opportunity for us to actually have quantifiable data that actually expresses specifically pain prediction. The ethics, the misuse of pain management or pain pills or any other way that doctors are currently addressing pain right now can be assisted in the idea that there are numbers that is shown in just the previous slide that are accurately describing pain. We're no longer just worrying about a 1 to 10 number. We're no longer worrying about a smiley face or a frowny face. We're actually able, hopefully, to give as simple as an app on your phone or on your Apple Watch. It reads the data that we're talking about, whether it's the blood volume pressure, the skin conductance level, or whatever else we find that's going to make this more accurate. And it's going to give us the chance to say, we can do this. You have pain. Not only am I going to help that pain go away, but even when you don't feel it near as much, your physiological responses aren't as much, you're going to be able to look at an app or whatever and say, I'm feeling this pain and it's time to change. And the doctor is going to be able to give an ethical, manageable pain plan.